Okay, I'm going to start within 2 minutes. Okay, so if anyone wants to join, please let them know. Okay, so the class is going to start within 2 minutes. Okay. Okay, let's start. Okay, let's share my screen with you. Okay, so today we also do pathology questions. There are round about 140 pathology questions, 11 questions of anatomy and embryology regarding the pulmonology, and 36 questions of physiology. We have covered physiology, anatomy, and embryology, and one block of pathology. Now we do this. Now we need to do two more blocks of pathology, and after that we will move to the pharmacology section. And hopefully within 3 days, almost 250 questions will be done. That is like a 6% of your whole unit. Okay. Okay. Let's start. Question number one. The patient pulmonary start from the last line. Pulmonary function testing. Okay. First, try to diagnose the patient. What is the age? 65. What are the symptoms? Worsening exertional dyspnea over the last 3 months. The patient's, for this past year, he had 4 respiratory tract infections. And alcohol, he has risk factor of smoking cigarette. And the most common disease whose risk factor is smoking is COPD. Okay. Diffuse breath sounds are diffusely decreased. Increased lucency of the lungs. Increased lucency of the lungs. Increased lucency, what does that mean? Increased lucency. Hyperlucency of the lungs. What does that mean? Okay, hyperlucency means that that the black part during which we see in the chest X-ray, that is increased, and when that the black part increases, that means the lung tissue density is decreased. Okay, when the lung tissue density is decreased, then you are going to see hyperlucency. And hyperlucency is common in what type of disease? It is common in COPD. Okay, it is common in COPD. You will see hyperlucency, barrel chest, hyperinflation, narrow mediastinum. Okay, all of these symptoms are you are going to see in COPD. Okay, it is a 65-year-old man worsening dyspnea, 4 respiratory tract infection. He has a risk factor of smoking cigarettes. His physical examination signs are much more consistent with COPD. Okay, now let's see which of the following things happens in the COPD. Okay, COPD is a obstructive lung disease, right? Right.
Yes.
Yeah, COPD is an obstructive lung disease, and we know that in obstructive lung disease, okay, let me see this word. Increase fluid lucency, increase lung field lucency. Okay, it occurs because of the decreased tissue density of the lungs. We know that the alveoli wall gets destroyed in the emphysema. That's why the tissue density gets decreased. The surface area available for the gaseous exchange is going to decrease. Okay, so it is in emphysema. Okay, now comes to the obstructive lung disease. In obstructive lung disease, we know that residual volume increases, functional residual capacity increases, TLC is also increased, total lung capacity increases. So option A, B, and C are not the right answer because in all of these the lung capacity is decreasing. Okay, forced vital capacity is increased or decreased. What happens to the forced vital capacity?
Decreased.
Decreased. Okay, option number F is also okay. What happened to the residual volume?
Increased.
Increased.
Forced vital capacity decreased, residual volume increased. Okay, so the option number D is the right answer. Okay. Okay. You can see here on page number 692. Residual volume increases, residual capacity increases, total lung capacity increases. First, you have to diagnose whether the disease is obstructive and restrictive, and after that, you can go to see hyperinflation. Remember this word as well. Okay, the vital capacity decreases. The forced expirate residual capacity increases. Residual capacity increases. Vital capacity decreases. Okay. Which of the following is the most likely cause of this patient's finding? Okay. First, try to diagnose the patients. A 32-year-old man, 32-year-old woman comes to the office due to exertional dyspnea that has progressed over the last year. She can hardly walk a block without stopping to rest. The patient's mother died of heart failure at age 40. No person can die at heart failure at age 40. Okay, that means that there's some other factors which are taking part here. Okay, and usually the women usually do not die from heart failure. During auscultation, the pulmonary component of the S2 is louder than the aortic component in the right and left second intercostal space. An accentuated impulse can also be palpated along the left upper sternal border. Chest X-ray shows clear lungs. Which of the following is the most likely cause of this patient's finding? Okay. Progressive dyspnea, exertional angina, loud pulmonary component. Do you people think that hypertrophic cardiomyopathy is the answer of this?
No.
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 Okay. Why you? Because if it is hypertrophic cardiomyopathy, then how are you going to explain the pulmonary component of S2 is louder than the aortic component? How are you going to explain the impulse which can be palpated along the left upper sternal border? Like this, that is left parasternal lift due to the right ventricle heave. How are you going to explain these two things? Okay, so hypertrophic cardiomyopathy cannot explain all of the findings in this patient. Okay, hypertrophic cardiomyopathy patient do die due to heart failure at an early age, but the other things cannot, other signs and symptoms cannot be explained by option number B. Okay, can left bundle branch block can explain this? Can left bundle
No.
branch block? Very good. Okay. Can hypertensive heart disease can explain this? Hypertensive heart disease.
Maybe.
No.
Yes. Left sided heart disease.
No.
Left
No.
ventricular
Because
hypertension.
if it is left side, it is a hypertensive heart disease, then the aortic component should be louder. Okay.
Yes.
Yeah, then the aortic component should be louder. Okay, because it will cause the closure of the aortic valve. Okay. Okay, so but in this case, the pulmonary component is louder, not the aortic component. Okay. Okay. Now, okay, okay, now we are left with two options: pulmonary hypertension and pulmonary valve stenosis. Okay, now let's open the Very hypertension topic. Okay, remember this. Often in females greater than males. Our patient is a female. Whenever you see a genetic, there are five groups of pulmonary hypertension. Group one is the one which included the cause, which covers the genetic component. Okay. Okay, in the genetic type of pulmonary hypertension, it will always be much more common in the females, and you will see a patient in the middle ages, and the patient will always be a female most of the time. Like, I think so there are 5 to 6 questions on pulmonary hypertension, and in all of these questions the patient is a female. Okay. And okay, so that can also explain the heart failure in her mother as well. Okay. And what type of mutation we see in pulmonary hypertension? BMPR2 gene mutation. Remember this as well. This is also very important. Okay. 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 And the loud P2 the loud P2 sound can also be explained by the pulmonary hypertension. Okay, the loud S2 sound the loud pulmonic component of the S2 sound can only be explained by the pulmonary hypertension. And that the attenuated impulse which we are seeing on the left upper sternal border, that is called left parasternal lift. Okay. Did that thing occurs due to the right ventricular hypertrophy. And why there is right ventricular hypertrophy here? Because there is pulmonary
Pulmonary
hypertension here,
hypertension.
which is leading to the increased afterload in the a, in the
Right
right
ventricle.
side of the heart. Okay, leading to the right ventricular enlargement. Okay, pulmonary hypertension. Okay, see this. When the right ventricular size increases, you are going to see parasternal lift, loud P2 sound, and right ventricular heave. And all of these three things are present here. There is a parasternal lift here, there is loud P2 sound here, there is right ventricular heave as well present here. Okay.
Doctor, will
Okay.
there be splitting also? Splitting of the S2?
Yes, there will be splitting of the S2 as well. There one is paradoxical splitting, and one splitting of the S2 sound is always available, is always there. But there are some changes which occur during the when anything happened to the aortic component or the pulmonary component. Okay, sometimes the aortic and pulmonary component comes closer to each other. Sometimes they get wider, and it depends upon different scenarios. Okay, whether there is pulmonary hypertension, or whether there it is arterial hypertension. Okay.
Got it. Thank you.
Okay. Splitting is a physiological thing, but the changes which occur in the splitting, that can help us to explain what type of that splitting is. It can be paradoxical. Okay. Okay, pharmacotherapy aimed at which of the following is most helpful in treating this patient's lung condition? Okay. A 65-year-old man comes to the office. Okay. 65, 6 months of exertional dyspnea, non-productive cough over the past few weeks. Medical history is notable for hypertension and hypercholesterolemia. Do not use tobacco, alcohol, or illicit drug. Okay. Late inspiratory crackles, and mild digital clubbing. Okay. Inspiratory crackles are heard when in restrictive or in obstructive.
Restrictive.
You will hear
Restrictive.
in restrictive. We have done this in the previous
Restrictive.
block as well. That inspiratory crackles are going to be heard in a restrictive lung disease. Okay. And expiratory wheezing is going to be heard in the obstructive lung disease. Okay. So that means the patient in this case is suffering from a restrictive lung disease. And the patient also has some digital clubbing. Okay. And we know digital clubbing occurs in which diseases? In which lung pathological diseases?
Restrictive lung disease, cystic fibrosis, bronchiectasis, lung cancer, lung
Cancer
abscess, and TB.
and there's one more disease.
Bronchitis.
Bronchiectasis.
Bronchiectasis and idiopathic
Yeah, pulmonary
pulmonary
fibrosis.
fibrosis as well.
Fibrosis.
Okay, these are the 5 diseases in which digital clubbing is present. Okay, histological examination shows areas of dense collagen fibrosis, foci of proliferating fibroblasts, mild interstitial inflammation, and honeycomb changes. Okay, honeycomb changes can be seen in both idiopathic pulmonary fibrosis as well as bronchiectasis as well. Okay, it's not like if you see honeycomb changes that mean it is going to be bronchiectasis. Bronchiectasis is a obstructive lung disease. Okay, you have to see the whole question. Okay, honeycomb changes can be found in both obstructive and in restrictive as well. Okay, is patchy and consists of lymphoplasmacytic infiltrate in the alveolar septa associated with the type 2 pneumocytes. Okay, let's see. Let's first try to find the diagnosis here. Digital clubbing, respiratory diseases. The first one, idiopathic pulmonary fibrosis, cystic fibrosis, bronchiectasis, and lung cancer. It can also be lung abscess and TB. And we know it is a restrictive lung disease, so it should be most likely pulmonary fibrosis. On the histology, he has mentioned there is a fibrosis occurring here, right? Okay. Now comes to the idiopathic pulmonary fibrosis. Let's see what is written in idiopathic pulmonary fibrosis. Peripheral reticular with traction, honeycomb appearance. Okay, honeycomb appearance. There is clubbing as well, non-productive curve, progressive dyspnea, associated with multiple cycles of fibrotic lung disease, inflammation. Decreased number of type 1, increased number of type 2, and fibroblasts. Right? See here, associated with, see the fourth last line, associated with hyperplasia of type 2 pneumocytes. Means increased number of type 2. And we have just read type 2 are increased in what? In idiopathic pulmonary fibrosis. Foci of proliferating fibroblast and fibrosis. That can also be explained by what? Idiopathic pulmonary fibrosis. So now we are all of us are sure that it is idiopathic pulmonary fibrosis. Yes. Okay. Now you have to tell me which of these things is associated with pulmonary fibrosis. Okay. Start with alpha-1 antitrypsin. Name the disease in which alpha-1 antitrypsin is involved.
Emphysema.
Emphysema. Okay. The drug we used against endothelium 1 is used in which disease? Endothelium 1.
Pulmonary hypertension.
Pulmonary hypertension. Okay. So option number B is also not here. Interleukin 5. The drug, the antibodies we used against interleukin 5. I think so. Their name are omalizumab and reslizumab. These are involved in which disease? Interleukin 5.
Asthma.
Asthma. Yes. So in asthma. Now we are left with two options: phosphodiesterase 4 and transforming TGF beta. Okay. Now you have to tell me which one. PD4 inhibitors. Do you know PD4 inhibitors are used in which disease?
Pulmonary hypertension.
Okay, let's see. Let's move on to the pharmacology. PDE4 inhibitors. And see here, anti-interleukin 5 monoclonal therapy. Okay, interleukin 5 is involved in. These are asthma drugs. Okay, interleukin 5 are in asthma, and PDE4 can be used in COPD. Okay, so none of them are related to idiopathic pulmonary fibrosis. Okay, and the endothelium receptor antagonist is in pulmonary hypertension. Okay, PDE5 are used in a pulmonary hypertension. Okay, so the right answer is option number E, transforming growth factor beta. Okay, and the drug we use for it is pirfenidone. Okay, think so. It is written somewhere in the immunology section. Let me search this. Pirfenidone is written somewhere. Pirfenidone, it is written. Because I know there are questions regarding pirfenidone in step 2 CK. I don't know whether it is written here somewhere or not. I think so it is written somewhere. Okay, let's move on to our next question. Okay, pirfenidone is an anti-factor. Remember this. TGF beta involved in fibrosis. Remember, TGF beta involved in fibrosis. Okay, let's come to the histopathological examination of the abnormal tissue. Okay, this is a lung tissue. 76-year-old man had worsening shortness of breath, tough, weight loss for the past several months. Lifelong non-smoker. Reveals irregular pleural thickening. Irregular pleural thickening. Surgical biopsy is planned, but the patient refuses, choosing to receive hospice care instead. He dies several weeks later, and a photograph of the cut lung section is shown. Okay. Okay. Can you tell me the name of the disease which affects the pleura? In the gross section, you can see there is pleural thickening.
Asbestosis.
Asbestos.
Yes, asbestosis can lead to what? Can lead to what?
Mesothelioma.
Yes.
Mesothelioma. Yeah, mesothelioma. Now we have to see, you have correctly diagnosed the patient, it is mesothelioma. Now you have to tell me which of these options is consistent with mesothelioma. Okay. Okay, let's see. Let's first read mesothelioma. It is written on page number. Asbestosis, there is asbestosis. Here, okay.
Sarcoidosis.
Polygonal tube histology shows soma bodies may show polygonal tumor cells with microvilli, desmosomes, stona filament, and calretinin and cytokeratin. Remember this one. Cytokeratin and calretinin 5/6 positive in almost all mesotheliomas. Okay. Smoking, tobacco smoking is not a risk factor. Okay. Let's move back to the answers. Okay. So which option number A, caseating granulomas with giant cell. You will see this in which disease? Caseating granulomas.
Tuberculosis.
TB.
and diseases.
TB.
Yes, you will see in tuberculosis. Okay. Central areas of hold collagen fibers. Do you know where you are going to see this? Central areas of hold collagen fibers. You are going to see this in silicosis. Okay. Small round cells positive for chromogranin.
Small cell lung carcinoma.
Yes, this is going to be, you are going to see this in small cell lung cancer. Okay, now we are left with D and E. Which one is the right answer? Is it D or is it E?
It's D. D.
Yes,
That
it
is
is cytokeratin. Spindle cells positive for cytokeratin. And what is the name of the other filament? Calretinin. Okay.
Carotene.
And
Yeah.
option number E is for empyema. Okay, think fibrinous exudate and pus. It is the empyema which occurs due to the pneumonia usually. Okay. Okay, let's move on to the next one. Treatment with which of the following is most likely precipitated this patient's current symptoms. Okay. Let's see. 72, 78-year-old, 2 days of nausea, vomiting, abdominal pain, and headache. She was recently hospitalized due to stroke, and hospitalization was complicated by a urinary tract infection and delirium. History of COPD and acute pulmonary increased theophylline. On physical examination, the patient appears agitated and restless. Is the cause tremor of the outstretched arms? Serum theophylline's level are markedly elevated. Okay. Okay, what is happening in this patient? There are symptoms of nausea, vomiting, pain, and headache. She was hospitalized and was complicated by a and hospitalization was complicated by a urinary tract infection and delirium. The patient has a COPD and a treatment includes theophylline. Temperature on the patient appears agitated and restless. There is a coarse tremor of the outstretched arm. Chest auscultation with mild expiratory wheezing. So serum theophylline's levels are markedly elevated. Okay. So what do you think what is happening in this question?
I think theophylline level is increased due to cytochrome P450 system activation with
Yeah, so
other
theophylline
drugs.
levels they okay, let's first see what are the do you people know what are the when the theophylline levels are markedly elevated, what kind of symptoms the person will show? Theophylline, okay, likely causes bronchodilation by inhibiting phosphorus in case of limited use. We no longer use theophylline now. Okay, due to narrow therapeutic index, limited use, and it can cause cardiotoxicity and neurotoxicity. Okay, metabolized by cytochrome P450 blocks action of adenosine. Okay, so the two main lines here which are important in for us: limited use due to narrow therapeutic index, and its toxicity can lead to a cardiotoxic signs and neurotoxic signs. Okay, and it is metabolized by cytochrome P450. Okay, so we see a coarse tremor, agitated and restless. So this can be explained by the neurotoxic due to the neurotoxicity of theophylline, because in the question it is clearly mentioned that the theophylline levels are markedly elevated, right? Okay,
Yes.
no, okay. Now we have to which of the following. Now it has also mentioned in the in theophylline that it is metabolized by cytochrome P450. Okay, and we have given the patient a drug for urinary tract infection. Okay, so now we have to see which of the following can be given in a urinary tract infection and has a linkage with cytochrome P450. Like we have to find a drug which is going to inhibit the metabolism of cytochrome P450, due to which the theophylline will no longer be getting metabolized in the liver and its level is getting increased in the blood. Okay. So do you know where the cytochrome P450 inhibitor drugs are written? They are written on okay. So they are so cytochrome P450 interaction. One are the inducers and one are the inhibitors. Okay, the inhibitors are the one which stop the cytochrome P450 enzyme, and when that enzyme is stopped, the theophylline drug will no longer be metabolized by the liver, and it is no longer be converted into its inactive form. And when it is not no longer be converted into its inactive form, the theophylline levels are going to get elevated in our blood. And we know when it is going to get elevated in our blood, what kind of symptoms it is going to cause: neurotoxic symptoms and cardiotoxic symptoms. Okay, now we have to see all the inhibitor drugs and see which one can be the answer in our case. Okay, there is sodium valproate, isoniazid, cimetidine, ketoconazole, fluconazole, acute alcohol, chlorpheniramine, ciprofloxacin, and prazole. Okay, so there is ciprofloxacin here. Okay, there is no haloperidol, there is no nitrofurantoin, there is no cephalexin, there is no. Okay, so this is all is written on page number 251 of pharmacology. Okay, and you can see the main four substrates are the OCPs, anti-epileptic drugs, and warfarin and theophylline. Okay, so like whenever you are giving these four drugs, always see the interactions with the other drug. Okay, see whether or not you are giving some drug which is a which is a inducer or inhibitor of cytochrome P450. Okay, always check for this. Whenever you starting giving patient either warfarin, anti-epileptic, or theophylline or OCPs, see what other drugs that person is taking. Okay, remember this. This is very important. Okay, so let's see which of the following is present. Okay, which okay though. So tell me which one is going to be the answer here.
C. C.
Yes,
Ciprofloxacin.
successful is going to be the answer. Okay. See, inducers, inhibitors, drugs mostly commonly affected: anti-epileptics, theophylline, and warfarin. Okay, dalstam, macrolide, equinolates, protease inhibitors. Okay, let's move on to the next one. Which of the following is the most likely diagnosis? Work of breathing increases respiratory rate. Okay. 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 So, can anyone explain what is happening here? What is happening here? Can anyone explain me?
In the patient, actually, the work of breathing is increased as well as a respiratory rate is also
Okay,
increased.
yes. Okay, so there are two things that are happening here. The number one thing is that you can clearly see that in the patient, the red line is at a higher level as compared to the red line in the normal patient, right? That means the area under the red line in the patient is higher. That means the work of breathing in the patient is higher as compared to normal. Okay, so this is the first thing. Okay, so now the second thing that is happening here, you can see the lowest area of this red curve. In the normal, it is at the 10 to 15 respiratory rate, right? And in the patient, that lowest area of this curve is it between the 15 to 20. That means in the patient, his respiratory rate is will be higher because the work of breathing is minimum at the higher rate. Okay, so can you people tell me in what type of disease people usually take a, a short and shallow breaths at a larger respiratory rate?
Asthma.
In asthma, do you think people take shorter breaths, shorter and shallow breaths?
No.
and
Emphysema.
at a higher respiratory rate.
COPD.
In obstructive
Emphysema.
lung disease, they take
Okay,
part.
okay. Let me tell you
Anxiety.
it. Okay, okay. Let's open first aid. Almost everything is written in your book. Let me tell you where it is written.
I think it's COPD.
Let's see. Let's see. What it is? Restrictive lung diseases. Presents with short and shallow breaths. Restrictive lung disease patients present with short and shallow breaths. Okay. Why? Because at a short and shallow breaths, they will have a higher respiratory rate, and at a higher respiratory rate, their work of breathing will be minimum. Okay, their work of breathing will be minimum at higher respiratory rate. Now, you people tell me which one is a restrictive lung disease.
Pulmonary fibrosis.
Yes.
Pulmonary
Fibrosis.
fibrosis. Okay, so in obstructive lung disease, respiratory rate moves backwards. It becomes to 10. And in restrictive lung disease, the respiratory moves a little bit higher. Okay, because the work of breathing is minimum at higher respiratory rate. Okay, let's move on to the next step. Which of the drug is most likely used in this patient? First, try to a 10-year-old one comes with an intermittent record. He's in trouble. Okay, so he is asking us that the drug works by the mechanism of action of the drug is by blocking the attachment of the inflammatory mediators with the receptors, with the cell surface receptors. Okay. How does albuterol works? What is the mechanism of action of a, and what is the diagnosis in this patient?
Exertional
Action.
asthma.
Action.
Bronchial asthma.
So what is the diagnosis in this case? Diagnosis.
Bronchial asthma.
Yes,
Asthma.
asthma. Okay, first eliminate all the drugs which we do not use in asthma. Do we use dextromethorphan in asthma?
No.
No,
No.
No.
no, we do not use dextromethorphan. Do we use apratropium?
Yes.
Yes. Yes.
No. Apratropium in COPD.
No.
Apratropium is for COPD. Okay, remember this.
Yes.
Okay, so now we are left with these 4 drugs. Okay,
Albuterol. Yeah.
okay, albuterol. What is the mechanism of action of albuterol?
Short-acting beta agonist.
It's
It is a
actually
beta agonist. It does
Beta
not block
agonist.
the interaction of
relaxes the
inflammatory.
smooth muscles.
Okay, yes, very good. Fluticasone. What is the mechanism? It is a steroid. Okay, so it is also does not work by
Steroid.
block. Now we are left in montelukast and xylotine. Okay, let's see montelukast and
Also
xylotine.
look at this.
Yes, montelukast.
Asthma-induced medication.
Okay, where is okay? Xylotine works by 5-lipoxygenase inhibitor. It does not interact with the it does not block the attachment of the of the inflammatory mediators with the receptors. How does Monte cover? By blocking the leukotriene receptors. Okay, by blocking the leukotriene receptors.
Yeah.
Okay, So our right answer would be
Montelukast. Yeah.
Montelukast. Okay.
Exercise induced
Montelukast.
asthma. Yeah.
Okay. So Montelukast. Okay, and you can also see that ipratropium. Ipratropium also is used for COPD, mainly used for COPD. Okay. 70-year-old man comes with severe right-sided chest pain.
Can we see the X bit?
Okay. Is this pleural effusion? Is this pleural effusion in this case?
No.
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 No. This
Okay,
is
very good. It is not. It is not pleural effusion. Okay. Is it emphysema?
No.
no. The
Very-
lungs
No.
are not flattened. That
Okay.
is
Not
Yes.
flat.
Yes. Okay.
diaphragm.
Lung markers are more.
Okay. It is. Is it pulmonary edema?
No, you cannot see
Not
this.
really, because
Lack of.
Pulmonary
okay,
edema, there is hesitation, glass node. The
Okay.
other
Yes.
picture, you know.
Okay. So, what is the diagnosis here? Can you see? Can you see this line?
Yeah.
Yes.
Yeah.
On
It
this
is
side.
like bronchitis,
Yeah.
See,
airway.
see,
Yes.
see this
Mhm.
demarcation here as well.
The
Yeah.
demarcation.
Yes. And there's black here and the black on the other side. And we know air always see when they
They're
when they
clavicles.
see it is appear as.
Sorry.
So what is the diagnosis here?
Bronchiectasis. Lung marker.
No, it is not bronchiectasis. The white. How going to explain that white line? How are you going to explain this white line? This is demarcating something. There is a separation. There is a clear separation here. That white line.
Pneumothorax.
A kind of vertical line.
Yeah, explain that vertical line by bronchiectasis. If you think it is bronchiectasis, how are you going to explain that? It is pneumothorax.
Explain. Yeah, pneumothorax.
It is pneumothorax. Okay.
Yeah.
Shortness of breath while doing hard work, replacement fails of a letter. And see the history. It is a 70-year-old man comes to the emergency department to a severe right-sided chest pain and shortness of breath after a fall. Okay, that is a very sudden
Trauma.
change in the lung pattern. You will not see such a change in bronchiectasis. Okay.
Mhm.
Okay. So now we are sure that it is pneumothorax. Okay. Now we have to see which one can be explained by pneumothorax. Bronchophony cannot be. Bronchophony occurs in which disease? Bronchophony is consistent with which one?
Consolidation.
Yes,
Everything.
consolidation. Let me open here. Bronchial breath sounds, egophony, bronchophony are with consolidation. Okay. And dullness, percussion, none. Okay, let's see. So wheezing is heard in which disease? Wheezing.
Asthma.
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 Dullness to percussion. Dullness to percussion.
This
It's
pneumonia
effusion.
or fusion.
Pleural effusion.
Prolonged expiration. Prolonged expiration.
Also bronchiasthma.
Yeah,
COPD.
COPD or yes, COPD. And we call this as pursed lip breathing. Okay. Now we are left with C and E. Which one do you think is the right answer?
E, because there is subcutaneous air that causes crepitus.
Yes. Right?
Surgical
And
infection.
yes, and the diaphragmatic expiration is okay. Diaphragmatic expiration is the distance the diaphragm moves between inspiration and expiration. Okay. The greater the distance the diaphragm is going to move, the greater will be the diaphragmatic exudation. And in pneumothorax, what will happen? That the air is going to flatten the diaphragm. It's going to restrict its movement with respiration. Therefore, diaphragmatic exclusion is going to be reduced. Okay. So the right answer is subcutaneous crepitus. Okay. Okay. Sometimes the
Because
air
cervical
also leaks
emphysema.
out into the skin, and due to the injury, it sometimes also leaked into the skin or the subcutaneous tissue of the chest wall. Okay, which can be detected as subcutaneous crepitus. Okay, it is pneumothorax. Okay, let's move on.
Also called as surgical emphysema.
Doctor, can you explain the exhibit again, if possible?
What do you want me to
The
explain?
diagnosis,
The
the
chest
exhibit.
X-ray.
Okay,
X-bit.
see, X-ray. Plural line without peripheral lung markings. Remember this thing. Plural line without peripheral lung markings. Okay. See this line. Okay. Okay. Now comes to the X-ray. Can you see that vertical plural line here?
Dr. Hasnain, I think this vertical line is of
Yes.
scapula, because we see
No,
the
no. It is not scapula.
scapular margin in the
No.
toe.
If it is scapula,
No, it
why
doesn't
this?
look
Right.
We can see like the lower angle of scapula in the.
But it goes beyond, so it's not.
Yeah, I think the
Doesn't seem like
fracture,
scapula.
fracture can explain. There must be some sort of fracture.
Yeah, there is a
Yes.
refracture, which refracture can puncture the lung and it cause right-sided. Yes,
Yes.
the lower this 1, 2, 3, 4, 5, 6 rib there is fracture.
Yes,
7,
exactly.
This one, right?
there is
This
fracture.
one.
It's
This one is
Yeah,
the right.
the
A little
black
bit left.
line.
Yes,
Yeah.
this one.
Yeah. This is the one where.
Just right to the scapular line. There is fracture. 6th, 7th ribs.
I think so.
Towards the sternum. Yeah.
I think so. You are talking about this, right?
no,
No,
that's
sir, a
more
little
lateral.
bit. Yes, the other side, right-sided
It's-
fracture there.
It's more lateral.
Okay. Okay. More left.
Yeah, close to the line.
Yes.
It's okay.
Where is scapula, the line is shadow. There is just right to the scapula, lower end. There is 2 ribs fracture.
Okay. Okay. I'm seeing trying to find the plural language. Okay. So usually when you are seeing pneumothorax, you are going to, the best way to differentiate between pleural effusion and pneumothorax is that pleural effusion you will see as an opacity as a whitish area. Okay, and we know that pneumothorax air is involved, and when the air is involved, you are going to see whole of the lung X-ray as black. You will not see any whitish area. Okay, most of the you will see some you are going to see some peripheral lung markings, but you will not see that whitish area as we see in the atelectasis, or you can see that in pleural effusion. You will also see that in consolidation, in ammonia. Okay, in all of these three you will see a whitish area, but in pneumothorax you will see only blackish area. Okay, so that is a very good thing to differentiate between the to differentiate pneumothorax from the other lung pathologies. Okay.
Doctor, here can the blackening in the skin in the chest wall, is that the air in the skin subcutaneously, the on the like right side lower part in this X-ray, right side, no more right,
You're
right,
saying
yeah, no, not the left, the right side, yeah,
you are
this
saying
air,
this is
yeah.
yes.
Oh,
That is
yeah.
subcutaneous air. That is a subcutaneous air, because air always be seen as black. Okay, because air is leaked into the subcutaneous tissue, and we can see here as a blackish area. This is, yeah, very good. That is a subcutaneous emphysema. Here it is not visible, but here you can see there is this blackish area just under the skin, the subcutaneous tissue, and that's why the answer in this question is subcutaneous crepitus. Okay. Okay, let's move on to the next question. Okay, with the nucleated cells in this patient perform which one? Are the cells, these white blood cells are granulocytes or agranulocytes?
Granulocytes.
These are granulocytes.
Granulocytes. Okay, so they have granules, small red color granules. Okay, and granules are neutrophils, basophils, eosinophils. Okay, neutrophils have usually how many nucleuses? The nucleus is how many lobed?
3
Multi-lobe.
to 5.
Multi-lobe.
Yes.
From 5 or
Yes,
yeah,
yes,
3 to 5.
yes. The neutrophil nucleus is always multi-lobe. Okay, but the and in which granulocyte there is a bilobed nucleus. Bilobed.
Eosinophil.
Eosinophil, they have a bilobe nucleus. Okay. Now you have to tell me what is the role of wait. Let me first see. Hematology, oncology. See, neutrophils are multi-lobe nucleus. Okay, multi-lobe nucleus. See the nucleus, it has many lobes. Multi-lobe nucleus. Neutrophils. And the now comes to the eosinophils. Has a bilobe nucleus. Okay, large granulocytes. Okay, and the function defends against helminthic infections, the parasitic infection. Okay, it is work against the parasites, asthmas, and the allergic processes. Okay, you see. Now comes back to the which one will be the answer here?
B.
B.
B. Destruction of helminths. Okay, because they are parasites. Okay, and we just read that it works against the helminthic infection with a bilobe nucleus and helminthic infections. Okay. Bilobe. Which of the following is the most likely underlying cause of this patient dyspnea? Okay. What are these?
Can we see the text again?
Can it,
These are telangiectasias.
These are
yes.
telangiectasia.
Yes.
The
Can you
skin
zoom
finding
again?
is
Can you zoom, doctor?
okay. These are telangiectasias.
Yes.
Okay. 31-year-old progressive dyspnea. Patient said that the shortness of breath improved initially with spine position immediately presents even on recurrency. And during minimum recurrent episodes of nosebleeds as well since childhood. Okay. So does this ring any bell? The patient has the telangiectasias, multiple nosebleeds. There it has this. Actually, this question is not of pulmo; it is of cardio. But you people have done with cardio, right? The patient has pulmonary hypertension as well, asymptomated as
As
hypertension,
the patient have telangiectasias and nosebleed,
multiple nosebleed.
Yeah, might be the patient have hereditary hemorrhagic telangiectasia.
Yes, hereditary Osler Weber Rando syndrome. This is actually a question of cardio. Cardio, I think it is written cardio.
Doctor, is it same? The spider angioma and telangiectasia are same or different?
Yes, they are same.
Okay.
Hereditary hemorrhagic telangiectasias, blanching lesions on skin, telangiectasias, and recurrent epistaxis, which is also present here. Okay. Autosomal dominant disorder of the blood vessels, AV malformation, abnormal high flow connection between the artery and veins. Okay, GI bleed, hematuria. Okay, it is okay. Osler Weber and Duke can explain all of these. Okay, so what will be the answer here then? If it is Osler Weber Rendu, what will the answer? Remember this.
Vascular malformation.
Atriovenous malformation also occurs in hereditary hemorrhagic telangiectasia. What will be the answer here?
E.
Vascular malformation, not valvular dysfunction, no pulmonary fibrosis. If it is pulmonary fibrosis, the lungs wouldn't be clear. Okay, it's not pulmonary fibrosis. No endocardial infection. If it is endocardial infection, if it is endocarditis, the temperature will be higher.
Temperature will be high. Yeah.
Higher. Okay, the lungs are clear. There is no airway obstruction. Okay, there is no valvular dysfunction. Okay, there is accentuated S2 sound over the upper left sternal border, which can be explained by the pulmonary hypertension. Okay. Okay, high output is complication. High output heart failure, pulmonary hypertension. Okay. Let's move on to the next one. Okay. Which of the following is the most likely underlying cause of this patient post-operative complication? Oh no. Suspected worsening from there is a large perirectal abscess. What two drugs the patient receives? It is a better reception. Can anyone explain me what is happening in this question?
This sucks apnea, I think.
Mechanism continued the patient successfully. So what is happening in this question?
Sucks apnea, called as sucks apnea. The long action of succinylcholine.
Yes.
Succinylcholine.
Okay, that's why. So he is telling in this question that usually when we give succinylcholine and propofol to a procedure, the patient comes back to the patient recovered from that in a specific time frame. But in this specific patient, he is taking a much longer time. Okay, and he taking like 2 to 3 hours longer than the other patients.
Yes.
Okay, and what is the cause here? Okay, why the person is taking longer?
Genetic polymorphism.
Because there is enzyme in the plasma that metabolize the succinylcholine.
Okay, so it is a very specific complication of succinylcholine. Okay, in some people, the pseudocholine esterase enzyme, which is used, which is responsible for the removal of the succinylcholine. Okay, Eh, in some people, that enzyme is a little bit deficient. Okay, and due to that deficiency, you will see a longer action action time of this succinylcholine. That's why the patient it takes the longer time. It takes longer time than the normal people. So it happens in many other things like they are slow acetylators, they are fast acetylators of a specific drug. It is a normal thing which can be happen to any person. Okay, it is not an we call this genetic polymorphism. Okay, so different people respond to drugs at a different rate. Okay, so let's first see. So it is again a question of neurology, and we haven't in neurology. It is not in pulmonology, so don't worry if you do not get this
It's
question
pure
right.
anesthesia, actually, you know.
Hmm?
Pure anesthesia question is this.
Yes, it is anesthesia question. It's succinylcholine increased risk of prolonged muscle paralysis in patient with pseudocholine esterase deficiency. Okay, so different people have different concentration of pseudocholine esterase. It depends upon on their genetics. Okay, some people have a much higher deficiency of pseudocholine esterase, due to which when they are given anesthesia through succinylcholine, they are going to take much longer time to recover from anesthesia. Okay, so this is genetic polymorphism. Okay, impaired hepatic function, no drug
Actually,
distribution, no.
choline, succinylcholine is two molecule of choline, acetylcholine, and for acetylcholine there is cholinesterase, but it's cholinesterase present in the neuromuscular junction. But pseudocholinesterase is produced from the liver and present in the plasma. It is the responsible for the metabolism of cholinesterase. In some patients, you know, there is some heterogeneous abnormality. Their effect may be prolonged for 30. It's very short acting, 5 to 10 minutes. You know, the
Yes,
effect of this oxygen. But in some patients, its effect, you know, if heterogeneous abnormality, it's prolonged like 30 to 35 minutes. If there is homologous defect, you know, genetically homologous defect, that it prolongs for 4 to 6 hours.
thinking whether this is written in pharmacology as well or not. Volume of distribution from clearance, selection. Patients who are slow acetylators have increased from certain because of the decrease. Okay, see, there's also a concept of slow acetylators and fast acetylators. That also depends upon on genetics. Okay, so some people are slow acetylators of drugs, and the other are fast acetylators of drugs. Okay, so in those people, the duration of action of the drugs will be different, and it is a normal thing in people. Okay. Okay, so let's move on to the next one. Okay. Which of the following measures would have been effective? Okay, so don't judge yourself if you get the previous question wrong, because you haven't studied that question right. Okay, right now, because you are studying pulmonology now, and that question is mentioned in the neurology section. Okay.
Yes, doctor.
Which of the following measures would have been most effective in preventing the patient's abnormal oropharyngeal findings? Okay. Now read the option.
Mm.
So the finding he is talking about is that there are white mucosal plaques that can be easily scraped off using a tongue depressor present in the oropharynx. The remainder of the examination shows no. He has he has a asthma problem which is controlled, which is not loading, and it did in the daily service added. Okay, can you tell me what daily inhaled therapy was added at the previous visit? Can you tell me the drug?
Steroids,
Steroid.
steroids,
Yes. Okay, when you are giving a person albuterol and his symptoms are no longer getting controlled with albuterol, so the second drug which we add after albuterol is a steroid drug, and it
Steroid.
is called step-up therapy.
It's
Okay.
steroids, yeah.
Yes, we will add steroid. Okay, and after adding the steroid, we are seeing that the patient has white mucosal plaques that can be easily scraped off. Okay, so what is the what is this white mucosal plaques that can be easily scraped off here? Can you
That's
tell me?
actually candidal thrush.
We have
That's
Oral
differential
thrush.
diagnosis with Candida, but he is not properly using the inhaler.
rat rash.
Yeah. They are oropharyngeal candidiasis. Okay, let me see. Okay, if they are not scraped off, then
Then it's oral
It's
leukopenia.
a
yes,
malignant, yeah.
yeah, Candida albicans, oral thrush, scrapable white plaque. Okay, scrapable white plaque. Unscrapable white plaque on lateral tongue, oral hairy leukoplakia. Okay, oral thrush. So now we are sure it is oral thrush. Now we have to see is oral thrush is a side effect of steroid or not. Let me open steroids. Okay, inhaled or oral glucocorticoids. Use use a spacer or rinsed mouth after use to prevent what? Oral thrush. Oral thrush is what? It is an infection of Candida albicans,
Candida.
a scrapable oral plaque. And how can we prevent that? Using a spacer or rinsement. Okay? Or rinse our mouth after to use to prevent oral thrush. Okay? Now you have to tell me which one is the answer here. How can we prevent the e,
C.
how yes?
Or
Rinse.
rinsing after
Right.
use.
See. Mm.
Either rinsing it
Use spacer.
or by using a spacer. Okay, inhaled glucocorticoids can be out of okay, that's next. The patient's improved oxygenation following PEEP application is most likely due to the decrease in which of the following. Improved or following PEEP. First, try to diagnose the patient. Yeah. 53-year-old worsening dyspnea, tachypnea, diffuse wet crackles. Wet crackles. Dry crackles are heard in which disease? Dry crackles. Can you tell me in which disease we hear dry crackles?
Fibrosis, yes.
Fibrosis.
Restrictive lung
Yes.
disease.
Yes. In fibrosis, you can hear dry crackles. Pulmonary fibrosis. Diffuse patchy infiltrates. AA gradient is markedly increased. These are wet pulmonary crackles. The pulmonary shares a and consummation is intubated and closed. She has hypoxemia. Okay, so the patient is suffering from what? Bilateral patch infiltrates, the patient
Pulmonary
has
edema.
wet freckles, and
Pulmonary edema.
AA gradient is increased. What is the diagnosis here?
ARDS.
Yes, it is pulmonary edema, which can be non-cardiogenic or that can be cardiogenic. Okay, and because the patient had diffuse bilateral patchy infiltrates, most likely it is going to be non-cardiogenic pulmonary edema. Okay, in non-cardiogenic pulmonary edema, do you see shunting or do you see dead space ventilation?
Dead space ventilation because due to water.
Let me open this.
Dead space.
Dead space. I think you see dead space.
Yes.
Okay. Current obstruction, shunt, airway obstruction. A gradient is increased. Okay. Okay, so the oxygen saturation improves with 100% oxygen and PEEP. Okay, which of the following is most likely due to decrease the improved oxygenation after applying a positive end expiratory pressure? Okay, do you know what is PEEP?
Yes, positive end expiratory pressure. It's
Positive
when
end expiratory pressure, and the
yes,
function of PEEP, like on at the
oh
end of expiration,
yes,
the pressure is going to be higher. Okay, that means positive and expiratory pressure. The pressure which is present at the end of the expiration cycle. Okay, usually it is lower, but in this we keep the end expiratory pressure higher. Why we keep the end expiratory pressure higher? To prevent the alveolar collapse. Okay.
So the
Prevent.
alveoli will be like more fluffier than normal.
Yes, so the alveoli does not get collapsed. We keep the end expiratory pressure higher. Okay, because usually what happens when during the end of the expiration, the pressure is very low. Okay, and there is very high chance of alveoli getting collapsed. Okay, and to prevent the alveolar collapse, we keep the P pressure high. Okay, we apply a higher end expiratory pressure. Okay.
Yeah, thank you. Got it. Yeah.
Okay.
actually, when the patient is on mechanical ventilation, it's opposite to the physiological breathing. You know, in normal physiology, there is inspiratory. Our breathing is by the effect of diaphragm, and there is elastic recoil. But when we put the patient on ventilator, we give artificial breath. When we give the means the inspiration by force, the alveoli open. When the patient exhale by the machine, there is a risk of collapse of the alveoli. That's why at the end of the expiration, we keep some pressure in the lungs to keep the alveoli open. That's why we applied PEEP, 5 to 7
Okay.
meter watt.
Okay. Okay. Now comes to the discussion of shunt or dead space ventilation. Okay, we know that there are two on a spectrum. There is one in which there is dead space ventilation. What happens in dead space ventilation? V over Q. In dead space ventilation, which one becomes zero? V or Q? In dead space ventilation, does
V.
V become
V,
zero or Q
V,
becomes zero?
V.
In that case, V becomes zero.
Q becomes zero.
Q.
That means dead space ventilation.
Yes. There is no
The
blood
Q
supply.
becomes there.
Yes,
There is
there is no
ventilation
circulation.
without
Yes, agree.
perfusion. Okay, there is ventilation without perfusion. Okay, and now comes to the other spectrum. Okay, on the other spectrum there is V over Q, in which V becomes zero. Okay, when V becomes zero, that means there is perfusion without ventilation. Okay,
Shunt.
okay, there is V is zero, but Q is not zero. Okay, that is called shunt. When there is blood supply but no ventilation, and when there is ventilation but no perfusion, that is called dead space ventilation. Okay, now tell me, in pulmonary edema, is ventilation becomes zero or the perfusion becomes zero? Which one becomes zero?
Ventilation is there, but there it's not reaching to be perfused. Sorry, to the perfusion level. It's not
Yes.
absorbed.
So if I say that ventilation becomes zero because the alveoli are receiving their blood supply, right? Every alveoli is receiving their blood supply. There is no obstruction there, right? There is no pulmonary edema. There is no pulmonary embolism there, right?
Yes.
So there is perfusion, but because now there is water or there is fluid within the alveoli, the air can no longer be able to reach the alveoli, right? Right or wrong?
Yes,
Yes.
right.
Yes. So that means ventilation becomes zero and perfusion, and then there is perfusion still present, and this condition is called shunting. Okay. And in that space ventilation, there is ventilation but no perfusion, okay, which occurs in pulmonary embolism. Okay. Okay, now you have to tell me by giving PEEP which of the following is going to is most likely due to which of the following is going to decrease, which of the following is going to decrease. Okay. Does the shunting which happens in this, is it intracardiac or is it intrapulmonary?
Intrapulmonary.
So E is not the answer, right? Okay. Does the lung compliance is going to increase or decrease when the condition improves?
Increase.
I think won't be
Increase.
affected.
Okay.
Doctor,
So
I did not
PEEP is going to
understand this.
improve. The lung compliance is going to improve. Okay. And he asked us which of the following is most likely to decrease. Okay. And we know due to through PEEP, lung compliance is going to increase. Okay. And in ARDS, the lung compliance decreases. And when you give the treatment to the person, it improves. Okay. Okay. Now we are left with three options. We know that it is not dead space ventilation. So A is not the answer. Now we are left with B and E. Which one is going to be the answer?
B, because
B.
the pulmonary vascular resistance is have no relation with P.
Yes. So B is going to be the answer. Okay. In intrapulmonary shunt, okay, VQ is zero when the ventilation is zero, and we call this shunt. Okay. And when the blood flow obstruction occurs, we call it dead space ventilation. Okay. In shunt does not improve foreign body aspiration. 100% oxygen does not improve PaO2. Okay. Okay. See, although the patient receives 100% oxygen via face mask, he has persisted hypoxemia. Can you people see this line? The patient condition does not improve on 100% oxygen. Its condition improved when we give it PEEP. Okay, its condition improved when we give it PEEP. Okay, and we have read just that in shunt, 100% oxygen does not improve PO2, which is consistent with our question. Okay. Okay. Okay, pulmonary edema, ventilation becomes zero, interpulmonary shunt not corrected with 100% oxygen, reduce the shunt. Let's move on to the next one.
Doctor, can you please explain a shunt here in terms of the lung? Because I couldn't understand the previous
Shunt.
question.
Okay, in shunt, first tell me V becomes zero or Q becomes zero. In shunt, which one is going to become zero?
I couldn't understand what is being shunted. Like I know in CVS we are shunting from right to left or left to right.
The blood is getting shunted. The blood is going to the alveoli, but it is not getting oxygenated. That means it is getting shunted. Okay, the blood is going to the alveoli, but it is not getting but it is not getting oxygenated. And why it is not getting oxygenated? Because the alveoli are no longer getting ventilated. Okay, because the V is 0. Why V is 0? Because now the alveoli are filled with fluid, and oxygen has and the air is no longer be able to reach the alveoli. So no gaseous exchange is occurring at the alveoli level.
Okay, so that is a physical barrier. The pulmonary edema is sort of physically preventing
Yes,
the.
it is a yes, very yes, yes, yes.
Oh, okay, thank you.
That's why AA gradient is also increased. Okay, AA gradient is also increased here. Okay.
Yes, thank you. Yeah.
Okay, let's move on to the next question. Dyspnea and weakness. Age of the patient 30 years. Female. Does not use tobacco, alcohol. Mother died due to similar symptoms at age 42. Some type of genetic condition. Lung biopsy reveals what? Medial hypertrophy, intimal fibrosis, decrease intraluminal diameter of the small branches of pulmonary artery. Medial hypertrophy, intimal fibrosis, okay, plexiform lesion, greater than in females, okay, increased in vasoconstrictors and endothelial vasodilators, okay. So what is the diagnosis here?
Pulmonary hypertension.
Pulmonary hypertension. Of what group?
Hereditary.
Hereditary, group number
One.
BMP.
1. Okay, group 1. Okay, which is the genetic one, the hereditary one. Okay, your mother died to the similar symptom at age 42. Okay, and the drugs we used for pulmonary hypertension, what are their name? These are the 3 drugs: bosentan, sildenafil, epoprostol, and alloprost. These are the drugs we used for pulmonary hypertension. Okay, which one is going to be the answer?
A. Bosentan.
Endothelial receptor antagonist. Okay, it is pulmonary hypertension, plexiform lesion. Let's move on to the next question. Okay, we have read this. Now, first try to diagnose the patient.
Look like COPD in patients because the diaphragm is flattened and
Okay. First, let's see the symptoms here. Due to shortness of breath over the last few months, some type of like chronic disease over the last few, and have begun to limit his daily activities. 50 pack years smoking history. Okay. The disease is mostly related to smoking, decreased breath sounds, and wheezing.
He started smoking from 12th year.
So 12 years, oh my god. And decreased breath sound and wheezing. Okay. And you can clearly see the lungs are here, are hyperinflated. There is a narrow mediastinum, and the diaphragm is in a straight line. Okay, you can see the diaphragm is in a straight line. The diaphragm is flattened. Okay, usually the diaphragm is curved. It is straightened here due to the hyperinflation of the lungs. Okay, and it happens in which disease? COPD. Okay, in COPD increased flattened diaphragm. Okay, you will see alveolar wall destruction, decreased DLCO, increased compliance of lungs, decreased recoil, and damage to the alveolar capillaries. Okay. Okay. Decreased DLCO, increased compliance. So the diagnosis here is COPD. Okay. Now, which of the following is going to be increased here? What will happen to the DLCO? Is it going to increase or decrease?
Decrease.
It's going to decrease. What happens to the FEV1? FEV1
decrease.
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 Yes.
Forced vital capacity
Decrease.
Oh, so as a decrease also.
decrease also. Lung elastic recoil.
Decrease. Only increase function residual capacity due to the increase in the residual volume.
And in obstructive, the residual capacity increases. Okay. The sputum findings are a result of finding a wish. Cells and crystals. So, what paroxysmal episodes of breathlessness and wheezing? Age is 24-year-old. Okay, 24-year-old means that it is not COPD. Okay, does not recognize any trigger for the end before that. Then he has no history. He had emphysema as a child. Okay. The patient has no medical tests of water in the lungs. Many granule containing cells. Okay, and crystalloid masses. Okay. Okay. What is the diagnosis?
Asthma.
Asthma is the diagnosis. He has emphysema, which can explain the allergy. Okay, so the patient is atopic. Okay, and that's why he has episodic episodes here. The granule containing cells are what? Those are granule containing cells are eosinophils. Okay, we have just read the granulocytes which are involved in asthma are eosinophils. Okay, and they are crystalloid masses as well. Usually the crystalloid masses are charcoal laden crystals. Charcoal laden crystals. Freshman eosin of charcoal laden crystals. Charcoal. Double pointed crystals found from the breakdown of eosinophils. Okay, they are seen in asthma. Okay, now you have to tell me which of the following is involved in asthma. TGF beta. We have just done a question on TGF beta. TGF beta involved in which disease?
Pulmonary fibrosis.
Fibrosis.
Interferon gamma. We have many
It's
questions on
tuberculosis.
Tuberculosis.
tuberculosis. Remember the IGRA test?
Teacher.
IGRA,
Yes.
interferon gamma release assay test, which is done for what? Tuberculosis. 1, 5, and 12. Okay. Interleukin 12 is also involved in which?
Tuberculosis.
Tuberculosis.
Okay. Okay. It is involved in TH1 cells differentiation. Okay. 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 What we used a antibiotic. We use a drug for the for a specific interleukin in asthma. Omalizumab, brazalizumab. At those drugs work against which interleukin?
Interleukin 5.
5.
Interleukin 5.
Yeah, because one
Interleukin
cause
5.
temperature, you know.
Yes.
Left only 5.
Anti-IL-5 monoleucal therapy. Okay, mepolizumab, rizalizumab against interleukin 5 because interleukin 5 is involved in asthma. Okay, it prevents the eosinophil differentiation, maturation, and all the interleukins are explained in a much greater detail in immunology. Okay, in immunology they are explained. Interleukin 5 prevents, promotes growth and differentiation, stimulates growth and differentiation of eosinophils. Okay. Okay. And interleukin 1 is involved in fever, acute inflammation. Okay. And this is a mnemonic: hot T-bone steaks, hot T-bone EA. Okay. It will also help you. Okay, let's move on to the next one. Interleukin 5, asthma, atopic asthma, used to know it. Which of the following characteristic is the most likely reason for this patient's anesthetic agent? Okay, I think so. This is again a question of that control administration. Ketamine. Okay, engaged. Okay. So what is this person is suffering from? What is happening in this question? There is hypotension here. Respiratory rate is higher. The patient severe respiratory distress.
Acute exacerbation.
Yes, asthmatic status.
Yes, the patient has an acute exacerbation of asthma, or due to which there is bronchospasm here, and the patient is hemodynamically unstable. Okay, so we need a drug which can help with the bronchospasm. Okay, and so he is asking why ketamine is why we use ketamine in this specific patient. Okay, so to know ketamine, you have to see neurology. Again, we have to go
Two
into
things. First,
neurology.
it's a sympathomimetic. It will improve the blood pressure, and it's bronchodilator also.
Neurology. Okay, in neurology, there are 3 types of intravenous and usually propofol, etomidate, and ketamine. So see here, ketamine is sympathetomimetic. It increases the blood pressure and heart rate. Our patient is hypotensive. its blood pressure is 90/60. Okay, 90/60. Okay, so we need a anesthetic which can increase the blood pressure. Other than that, the patient appears in severe respiratory distress. The lung reveals bilateral wheezing. Okay, and it also causes bronchodilation. Okay, this we're discussing about ketamine. Okay, so this will solve the two issues which is occurring in this patient. Okay, that's why we are using ketamine here. Okay. Okay, so what will be the answer then? Sympathomimetic
Is
activity.
symptomatic activity.
Okay, that's why we are using ketamine here to solve the two issues which this patient is suffering from. Okay, it is written in neurology pharmacology. Okay, not in the pharmacology. Okay, let's move on to the next one. Okay, this diagram is much more clear. Okay. So can you in this diagram see the narrow mediastinum here? The mediastinum is narrow, very narrow.
Yes. Yes.
Yes.
Hyperinflated lungs.
And you can also see the hyperinflated lungs as well. See? And so what will be the diagnosis here?
COPD.
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 COPD, M5C. No?
I see.
The X-ray is very clear here. Okay, which of the following is most likely to increase in this patient? Increased. Okay, DLCO, is DLCO increase or decrease in COPD?
Decreased.
It's decreased. Forced expiratory volume.
Decrease.
Forced expiratory volume in 1 second.
Decrease.
And forced vital capacity in
Decrease.
residual. Okay. Forced vital capacity. What happened to the forced vital capacity?
Decreased.
Okay. And the residual volume?
Increased.
Increased.
Total lung capacity?
Capacity is
Total
also
lung capacity?
Increased.
Increase. Okay. So
Increased.
and remember we did one question. I think so. One day ago we did one question in which there is a graph, and in that question we talked about how the change in residual volume is greater than the change in the lung capacity. Remember? We
yes.
solved one question in which we have talked that both of them are increased, but the change in residual volume is much larger as compared to the change in lung capacity.
Yes.
Yes. And that's why the ratio here is increased.
Increased, exactly.
Okay, because the change in residual volume is larger as compared to the lung capacity ratio. Okay. Okay. We have solved that there's a graph of two, one is normal and the other graph is for COPD. And the answer of that question is also this ratio. Okay. Okay. An inhaled corticosteroid is Inhaled corticosteroid is prescribed to achieve better symptom control. Okay, so the patient was using an albuterol inhaler. Then we added a steroid. While and he is asking, in addition to the anti-inflammatory effect, which are the following also directly also results as of this. Okay. Okay, so this concept is also not written in the pulmonology section. We have to go into the general pharma. It's mentioned in the general pharma. Where it is.
It was also mentioned in cardiology that the
Yes.
steroids cortisol permissive,
Yes.
with the sympathetic drugs.
See this. Cortisol on catecholamine responsiveness. Presence of substance A is required for the effect of for the full effect of substance B. This means 2 plus 0 should be greater than a 2. A 2 plus 0 is equal to 2. Like that, the cortisol increases the permissive effect. It is increase the responsiveness of the catecholamine responsiveness. Okay. So this cortisol is a steroid. Albuterol is the one which acts on the beta 2 receptors, on the catecholamine receptors. And the presence of a steroid is going to increase the responsiveness of the receptors to the albuterol. Okay. This is called permissive effect. Okay. What it is called? Permissive effect. Okay. Now comes to the question. So what will be the answer here?
E. Increased responsiveness of beta 2 receptors.
Yes. Okay, because it does not increase the activity of phosphodiesterase. It does not decrease the viscosity of bronchial mucosa. It has no effect on lung surfactant. Increased quantity of surface bound Ig, no, it decreases the quantity. Okay, so the answer is increased responsiveness. Potentiating it upregulates the beta 2 receptor in bronchial smooth muscles, increasing the cellular responsiveness. Okay, have no direct effect, but it can potentiate the bronchodilatory effect. Like 0 has by itself does not have any effect, but it can potentiate the effect of beta 2 agonist of albuterol. Okay.
And we also give in
So
patient with septic shock when we give the IV fluid and giving the inotropes and still blood pressure is low, then we give glucocorticoid to improve
yes,
the norepinephrine and others.
yes, to upregulate the alpha 1
Receptors
receptors.
also. Yes.
Yes, you are right. Okay. Let's come to this question. 62-year-old man comes to the office for evaluation of progressive dyspnea, traditional dyspnea, significant pneumonia, 45 years. Lung condition. Okay. 45 degrees. Wheezing and decreased breath sound, and a 45 pack year smoking history. Diagnosis.
COPD also.
Yes, 45 pack year smoking history and decreased breath sound and wheezing. Okay, wheezing, either you will see wheezing in COPD or in asthma or
Yes.
okay. And you can clearly see that the patient has dilated air spaces here.
Yes.
Okay, the patient
Dilated
has dilated.
bullous there in the city.
Okay, the patient had dilated air spaces here. Okay, and we have learned what type of cells are involved in COPD. Can you tell me the names of the cell?
Neutrophils, macrophages,
And
the third one, yes, CD8.
Yes.
CD8 cells.
Yeah.
Mediated by oxidative stress, chronic inflammation, CD8 plus T cells, neutrophils, macrophages, and imbalances of proteases and immunity elastases. Okay, so these are the cells which are involved in here. Where distal frequently tuberculosis working, centriacina. Okay, so which of the will be the right answer here? D, right?
D.
Neutrophils are involved, and there are no option for macrophage and the CD8 T cells. Okay, and can you tell me, is it centriacina or panacina? The emphysema here is it centriacina, because panacina effects occurs when lower lobe
Alpha 1
and alpha 1 antitrypsin deficiency. Okay, it occurs much more earlier. The patient age is 62. Okay. Okay. This centriacina emphysema. Okay, smoking risk.
But doctor, how could we find from that CT it was not in the lower lobe?
No, we cannot find from the CT that it is not in the lower lobe. We see that the patient has a smoking history, and its age is 62, which is much more consistent with centriacina. The panacina does not require smoking history, and it occurs in a much earlier age. Okay.
Panacina is associated with alpha 1 antitrypsin deficiency.
Yes,
na?
yes, yes.
Yeah, thanks.
Okay, which of the following is prescribed that reduces? So read this line very carefully. Reduces the nicotine cravings and decreases the pleasurable effects of cigarette and other tobacco effects. Okay. So you have to see which of the following drug reduces the nicotine cravings and decreases the pleasurable effects. Okay. Does clonazepam is used in smoking cessation?
No.
No.
Does SSRIs are used in smoking cessation?
No.
No.
Does anti-epileptic drugs are used in smoking cessation?
No.
Anti-epileptic. Okay. So okay, we are left with nicotine patch in vernicide. Okay, I don't know. Since it is written DPT. Okay. Pharmacotherapies for smoking cessation. One is nicotine replacement therapy. One is vernicide. Okay, now read carefully. Nicotine patches bind to the nicotinic receptor, aims to relieve the withdrawal symptom. Upon stopping smoking. Long-acting patch and short-acting products can be used in combination. Now comes to the vernicillin. Vernicillin is a partial agonist, diminishes effect on reward system, but also reduces withdrawal. Okay, vernicillin helps nicotine cravings decline. Okay, adverse GI okay. So now you have to tell me which one of these are going to reduce the nicotine cravings. Is it nicotine patch or is it vernicillin?
Vernicillin.
Okay. Vernicillin helps nicotine cravings. Okay.
But doctor, giving nicotine will also decrease the cravings, no? Because he's getting it from.
nicotine does not reduce the nicotine cravings. Okay, you are giving nicotine to reduce the nicotine cravings.
Yeah, because it says you can give nicotine gum and lozenges. So I'm confused now.
Nicotine gums for smoking cessation. It's not to reduce the nicotine, it is to reduce the nicotine withdrawal. Okay, it is used for smoking cessation, not for nicotine, not to reduce nicotine cravings. There's a difference between reducing nicotine cravings and to use for smoking cessation. Okay, nicotine patch is used for smoking cessation. Okay, but it is not used for reducing nicotine craving. Did you get my point?
Yeah,
Okay.
kind of. Yeah, yeah.
It will stop
Nicotine
the.
seem like smoking without smoke.
Yes. Nicotine patch is like giving nicotine without smoke. Okay.
So effect, matlab, sorry. So it's like reward is getting less with the that other drug.
Yes.
That is the difference.
Yes, reward is also getting less, and it is a partial agonist, and it is not nicotine as well. It is reducing the nicotine cravings. Okay. The other one is nicotine. Pernicycline is not nicotine.
Okay. Partial agonist. Thank you.
Okay. That's why I said that read this line very carefully, because most of the people gets confused between nicotine patch and vernicycline. Okay. Which of the following is most likely to see only influence values? Okay. Read this option. Now try to read the question and try to make a diagnosis here. Okay, what are the symptoms here? Anterior uveitis, or swelling of the parotid gland, enlarged lymph nodes, nodular pulmonary infiltrates.
Yes.
Okay, and all of these can be explained by what disease?
Sarcoidosis.
Sarcoidosis, parotid enlargement, ocular uveitis, granulomas occurs, erythema nodosum, enlarged lymph nodes, bilateral hilar adenopathy. And okay, now comes to the answer. What will be the answer then? We see it is going to be C, granulomatous inflammation with no central necrosis, because it is non-caseating granulomas. Okay. Which of the following hemodynamic parameters? Okay, see the options. The question. Okay, so what is happening here? 65-year-old woman, COPD. Okay, the patient will increase shortness of breath, relieved by inhalers. 45 pack year smoking history, which is leading towards the COPD. Oxygen saturation 91%. JVP is elevated. Okay, JVP is elevated. Increased intensity of pulmonary component of S2 as well. Breath sounds are decreased bilaterally, scattered wheezing, no crackles. Why there is GVP elevated and increased intensity of pulmonary component of S2?
Right heart failure.
Right
Right.
heart failure due to the
Right
yes,
heart failure.
COPD.
Okay, the right
Yes,
heart, and why
orthogonal.
there is the right heart failure?
Pulmonary hypertension.
pulmonary hypertension, and that's explain the increased intensity of pulmonic component of H2. Okay, can you tell me what group it is? Hypertension due
Group
to
2.
pulmonic hypertension due to emphysema.
Emphysema appears of
Group 3.
hyperinflation inflation of the lungs, which
Group-
press the capillaries and the small.
I'm asking what
Three.
group it is. Group.
Group 3.
Group 3.
Group 3.
3.
See, lung disease or hypoxia, group 3, destruction of COPD, and obstructive can leads to pulmonary hypertension. So, you have to tell me the answer. Which of the following is going to be increased? We know it is of right side, so A and B are not the answer. C, D, and E. Pulmonary capillary
E,
wedge pressure
yes.
represents
Hmm.
the left side
Left
left
side.
atrial pressure.
Pressure.
So the right answer is going to be
E.
Right
The right
ventricle.
ventricular afterload will increase.
okay. Okay. So we want to- Okay. Okay, so can anyone explain me what is happening in this photo?
This is a sleep study, and the lower graph is containing the chest cavity, the activity, and the upper one, green one, showing the airflow through the means the respiratory tract, and there is cessation, means there is a cessation of the airflow. That means there is you have some episode of
Apnea, sleep
yes,
apnea.
apnea, yes,
Apnea.
maybe hypoventilated is now you can say the obstructive sleep apnea,
Yes, it is a sleep study, and you can clearly see there are patches in the airflow which have a flat line. That means there's no airflow is occurring at that time. That is apnea. That during some sleep there is some apnea is occurring, and we know sleep apnea occurs in which disease? Obstructive sleep
Obstructive sleep
apnea.
apnea, in ovarian,
Okay.
yes, morbidly obese patients.
Morbidly obese patient. Okay. So they have removed the sleep apnea. So what would be the answer then?
E. Upper airway.
The upper
Airway
obstruction.
Obstruction. Okay.
When-
Upper airway obstruction. Usually caused by excess oropharyngeal and parapharyngeal tissue in adults, okay, which causes the obstruction of the at the neck area, and that leads to sleep apnea, okay, and causes airway obstruction, okay. Okay. Obstruction function. Decline is most likely to increase in tissue deficit. Okay.
Oh, yes.
There's a 60-year-old woman comes to the emergency department due to shortness of breath, productive of emergency department. Okay. Okay. 30 pack years smoking history, 88% on room air, appears uncomfortable, accessory muscles for breathe, Expiratory wheezes are heard throughout the lungs. Supplemental oxygen, the patient is starting on high flow oxygen supplementation. Shortly afterwards, she becomes increasingly lethargic and confused. Okay. So what is the diagnosis here? Expiratory wheezes are heard in which disease?
COPD.
COPD. So the patient has right now has an acute exacerbation of COPD.
Solution of COPD.
Of COPD. Okay. So in step 2 CK, when you are going to learn the management of acute exacerbation of COPD, so there is a concept like when you give oxygen to the patient, you will keep the oxygen of the patient only up to 92%. Okay. Like in this patient, the oxygen is 88%. When you started the oxygen, you will keep the oxygen saturation only up to 92%. And there's a reason for that. Okay. When you give oxygen to a person, what will happen? What will happen to the respiratory rate? Is it going to increase or decrease?
Decrease.
Decrease.
Yes.
If the respiratory rate is going to decrease, what will happen to the dissolved carbon dioxide?
Hypercapnia.
Okay, the respiratory rate is going to decrease, and due to which carbon dioxide level in the blood are going to increase. Right? And when they are going to increase, they are going to cause symptoms like lethargy and confusion. Right? And this is called oxygen-induced hypercapnia. Okay?
Yes. Carbon dioxide narcosis when they increase
Yes,
PCO2 more than 70.
Okay. So you have to tell me which of the following is going to be increased in this patient. Pulmonary vascular resistance, is that going to increase or decrease, or you are going to see when you give oxygen, what will happen to the pulmonary vessels?
Oxygen decrease pulmonary vessels.
Yes, because hypoxia causes pulmonary vasoconstriction. And when you give oxygen, you will see pulmonary dilation, right? So that is not the cause of here. That is not the cause here. Okay, so when the vessels are going to dilate, the resistance is going to decrease, right?
Yes.
Okay. Reactive oxygen species production.
Yes, could be increasing with a high concentration of oxygen. Yes,
it can be.
Yes, that can be the answer, but the main pathology we are seeing here is not due to this. Okay, reactive oxygen species production occurs 24 hours. It takes usually 24 hours to develop. Okay, the damage due to oxygen toxicity takes some time. Okay, that
it's more
can occur
harmful
in this patient,
in
but
neonates,
that cannot
especially
explain the lethargy and confusion. Okay, that cannot explain the lethargy of confusion. If it is oxygen toxicity, you will see pleuritic chest pain, cough, dyspnea, substernal heaviness. But the symptoms here are lethargy and confusion.
Acidosis.
Okay, that cannot be explained by the reactive oxygen species. Okay, reactive oxygen species are going to form within the lungs, and they are going to cause damage there. Okay, they are not going to affect your brain. Okay, so that's why B is not the answer. Okay, is renal bicarbonate reabsorption is what will happen?
It can happen, but it's actually late phenomena, not.
Yeah, it takes time. Okay, what will happen to the respiratory minute ventilation?
Minute ventilation.
It can increase.
Respiratory rate
decrease.
decreases.
Respiratory minute ventilation means pedal volume
decrease.
into respiratory rate, and here is hypoventilation. It will decrease.
Yes. Okay. So the right answer is ventilation perfusion mismatch. Oxygen induced hypercapnia. Okay, pulmonary vasodilate, increase alveolar dead space, vasodilation, and COPD oxygen induced carbon dioxide. Okay. Let's move to the next one. Pathological process involving which of the following most likely to cause So is most likely the cause of this patient respiratory shortness of breath, reduced lung.
Doc, I have a question. How was that last answer, ventilation perfusion mismatch? I understand why all the other ones was wrong, but I don't understand why that one was right.
Okay, I got your point. Okay, so how does oxygen act? Okay, the major effects of oxygen, one is that there is pulmonary vasoconstriction. It will cause vasodilation. Okay, so the vasodilation diverts the blood from a well, it diverts blood from the well ventilated regions, okay, into the other areas. So it will increases the alveolar dead space ventilation. Okay, because oxygen is present everywhere, even the bad alveoli will also see vasodilation. So now the bad alveoli will get the blood supply, and due to which this dead space ventilation is going to increase. Okay, because when there is oxygen available, it is going to cause vasodilation. Okay, and in this way the VQ mismatch is going to increase. Okay, like if a good alveoli gets a good if a good alveoli gets good blood supply, that's okay. If a bad alveoli gets a bad blood supply, that is also okay. But if a bad alveoli gets a good blood supply, that is a mismatch. Okay, the bad alveoli should get a bad blood supply. Okay, but by giving oxygen we artificially increase the blood supply to that area as well. So in this way a bad alveoli gets a good blood supply, that is going to increase the mismatch. Okay.
Okay, thank you.
Okay, the pathology is most likely to be cause of this patient shortness of breath. Try to diagnose this. Okay. Okay. The age is 62. Progressive weakness and dyspnea. It comes to the emergency department. So always see whether the visit is a emergency one or a regular visit. Okay. So that is also very important along with the age of the patient. Emergency department, progressive weakness and dyspnea. Who forget to bring her who says that if patient forget to bring her regular medications and has not been taking them for the past week, okay, began feeling weak and fatigued for 3 days ago, weak and fatigued 3 days ago, blood pressure is normal, respirations are 24/40 and shallow. Compare this drooping of the eyelids and the corner of the mouth. Speech has a nasal quality. Okay. Room air 7.32, carbon dioxide elevated, oxygen decreased. Okay. Forced vital capacity decrease. So, what is the diagnosis here? What main pathology in which you are going to see dropping of the eyelids, dropping of the corner of mouth when the patient stopped taking medication? Most likely it is a chronic type of problem which is also affecting the muscles here, right?
Myasthenia gravis?
Myasthenia
Yeah,
gravis.
gravis. Very good. It is myasthenia gravis. Okay, now the patient go into myasthenia crisis. Okay, and because the patient goes into myasthenia crisis, myasthenia usually affects what type of tissue? The muscles. Okay,
Muscle,
okay, so
Muscles.
yes, it affects the nerves receptors, and when the nerve receptors are no longer present, the muscles are no longer be able to work in their usual way. So the main problem that is occurring here is where at the muscles of respiration, right?
Yes.
Yes.
The diaphragmatic muscle. Okay, global hypoventilation, muscle weakens. It is written in the MSK. I think so. It is written in the MSK. Or it is written in the MSK. Yeah. The myasthenia gravis worsens with muscle use, fatigable muscle weakness, ptosis, respiratory muscle involvement, dyspnea. Okay, worsens with muscle use. Okay, because okay.
Doctor, your battery is getting very low. It's 6%.
Okay, I will charge it. Don't worry. Okay. Okay. ECG shows right axis deviation. Patient condition is inherited. Which of the following is the most likely primary cause of her disease? Okay. Now, first try to find the diagnosis here. 34-year-old age, a 34-year-old, she's a woman, progressive exertional dyspnea for the past 6 months. No chest pain, lightheadedness, or syncope. Unremarkable, does not use tobacco, alcohol. Patient's mother died of pulmonary arterial hypertension. Breath sounds are clear without wheezing, loud as to at the left upper sternal border. ECG shows right axis deviation. Right axis deviation means
Right hypertrophy.
right ventricular hypertrophy. Okay, so what is the diagnosis here? She's a woman, right axis
Pulmonary
deviation,
hypertension and
pulmonary hypertension.
Again,
Type
pulmonary
1.
hypertension.
Type 1.
Okay. Okay, so what is the primary cause of her disease? Is it C?
alpha 1 antitrypsin.
Is it C?
No.
If the but you people told me that the patient has right ventricular hypertrophy. Then why not the answer is C? The patient had right axis
It's type
deviation.
1.
Primary cause.
They're
Type
asking
Yeah,
primary
the
cause.
the
1.
examiner is
PMPO.
asking the primary cause. The right ventricular hypertrophy is the effect. It is not the cause here. It is the effect. Okay, that's why even the C is present here. He is not the cause. Okay, you have to see what he is specifically asking. Okay, okay. Elevated left atrial pressure, is elevated left atrial pressure present here? No.
No.
Is the a patient is the diagnosis here is pulmonary embolism or pulmonary hypertension? It is pulmonary hypertension, right?
Pulmonary hypertension. Yeah.
So D is not the answer. So what will be the answer?
B.
E.
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 Vascular smooth
E.
muscle proliferation. And what gene is involved? Name of the gene.
BMPR2?
EMP.
BMP2?
BMPR2 gene.
MPR2.
Yes, which is called muscular smooth muscle proliferation. Is written in the page.
We solved a similar question today.
Yes, vascular smooth muscle proliferation. Like this is the fourth or fifth question on pulmonary hypertension. Females normally inhibits the PE vascular smooth muscle proliferation. Okay, BMP2 gene is involved in vascular smooth muscle proliferation. Okay, which of the following is accelerated is most likely contributed to the later observation in this patient? Okay. Okay, so what is happening here? Arterial partial pressure of oxygen is normal at rest, but falls significantly with exercise. And he is trying to ask us why it is falls significantly with exercise. Okay. And what is the diagnosis of this question? Worsening shortness of breath or the last.
Exercise induced asthma. Good.
The patient has a inspiratory crackles. There is most likely some kind of interstitial lung disease. Also can be lung fibrosis or anything like that. It is not obstructive. Okay. And
What does that diaphragmatic excursion decreased mean?
that the movement of the diaphragm during the expiration to the inspiration, the total distance it covers, that is reduced. Okay. Okay, now he's asking why during the exercise that the oxygen falls significantly during exercise, and it is normal during the rest. Okay, I have told you a concept regarding the oxygen diffusion. Oxygen diffusion requires time, and carbon dioxide diffusion requires comparatively less time. Remember that?
Yes, you said
Yes.
so.
Okay. So during exercise, the perfusion, the amount, the time during which an oxygen molecule remains in the alveoli would be higher or lower during exercise. It will
Lower.
be lower.
Low.
Okay, because the blood flow is going to increase, right?
And
So
rate
the
also.
oxygen molecule that is going to stay in the time that it will stay in the alveoli area is going to be low. And we know that oxygen requires time, and because the perfusion rate increases during the exercise, that's why the oxygenation falls. Okay, so the right answer would be here: increased pulmonary. Yes, increased pulmonary blood flow. Because of the increased pulmonary blood flow, the amount of time at which an oxygen remains in the alveolar area where the main gaseous exchange occurs will be low. Okay? Okay.
Doctor, can you repeat, please?
Okay, I will repeat this concept. Okay, oxygen. Okay, diffusion limited oxygen. Oxygen requires time to. Oxygen requires time for diffusion. Like like if you want to suppose there is a shop, and if you need to pick 10 things from that shop, you require 8 minutes. Okay. Okay, but if you stay at that shop only for 5 minutes, how many things you can pick up at that place? It should be less than 10, right? Okay, same things happen with oxygen. If oxygen remain, if the oxygen if the hemoglobin stays at a smaller time at the alveolar area, less oxygen will be diffused from the alveolar air into the blood. Okay, because it is time dependent. The lesser the time, the less oxygen will be moved from the alveoli into the blood. Okay, it is not like carbon dioxide, which requires very less time. Okay, oxygen requires time, and with increased blood flow during the carbon dioxide during the exercise, the time period during which the blood stays in the alveolar area will be shortened. Okay, that's why we are seeing less oxygenation during the exercise. Am I clear?
So
Did you people able to understand the concept?
So the diaphragm thing here was explaining that this patient is having fibrosis.
Yeah, the diaphragm thing is not very relevant regarding the concept here.
Okay.
Okay.
So,
It is only
so during the exercise, when blood flow increased, then what happened to the oxygen?
during exercise that the blood flow is going to increase. What will happen to the time period how much does the blood will stay at a larger time now, or the time period will be lower?
Time period will be lower.
Be lower. Okay.
Very
And
fast.
yeah, the time period will be lower. At the blood will stay at a lower at the, like if it's slow blood flow, if it takes 10 seconds, now the blood will only going to stay for 5 seconds here, right?
Yes.
Now it is going to, the time period is going to be lower, and we know that oxygen requires time to diffuse. Okay, for the diffusion to occur, oxygen requires time. If the time is shortened, so now less oxygen will be moved from alveoli into the blood. Okay,
Yes. Yes.
because it is perfusion limited. Okay.
But if this was a normal patient without that fibrosis, he would have increased the VQ would have approached 1 because of that exercise.
Yes, yes, yes. In the normal people, it will not be a bigger issue, because in normal people, you will not have fibrosis. Okay. In normal people, it will not causes a decrease in oxygenation. Okay. But in this specific case, because the patient has already fine inspiratory crackers, diaphragmatic expiration is decreased, the patient has a patient of lung fibrosis, who has already have increased AA gradient. All of these are contributing that the patient has a very small window, and he cannot compensate enough. Okay. Okay. So can I move to the next question?
Yes.
Okay. Which of the following is the most likely cause of the patient's hypotension?
Actually, one last thing. What was the diagnosis of the previous question? What was the
Lung
problem?
fibrosis, interstitial lung disease.
Okay. Thank you.
It is a restrictive lung disease most. 65-year-old, hypotension, increased shortness of breath shortly after placement of right-sided subclavian venous catheter. Right-sided subclavian venous catheter. The patient was recently diagnosed with colon cancer without metastasis. Blood pressure is 80/50. Respiration are also increased. Shows jugular venous distension. Breath sounds are decreased. Trachea is deviated on the left. Okay, can it is, what is the diagnosis here?
Pneumothorax.
Pneumothorax.
What
Tension
type of
pneumothorax.
pneumothorax?
Yeah, tension
Pneum-
pneumothorax.
Tension pneumothorax.
Tension pneumothorax. Air enters in the space but cannot exit. Increased when cause trachea deviates. Trachea deviates from the affected lung. May lead to increased intrathoracic pressure, mediastinal deviated, kinking of the inferior vena cava, due to which the venous return is going to decrease, cardiac output is going to decrease, hypotension, tachycardia, jugular venous distension. The main reason is kinking of the inferior vena cava. Why kinking? Due to the increased intrathoracic pressure, which is exerted by what? Increased air. Okay, due to the tension pneumothorax. Okay, okay, and why that pneumothorax is occurring? Due to this, that central line placement. Okay, that is the reason here. Okay, okay. So what will be the answer here?
See.
Yeah,
Decreased venous
decreased
return,
venous
because
return.
inferior vena cava is kinked, and due to which the venous return is going to decrease. Pneumothorax, decreased, kinking, decreased venous return.
Doc, you should get your charge.
Okay, after this question, I will bring my charger.
In the previous question, the JVP was raised because the lung was giving external compression to the SVC.
Yes, because there is an obstruction at the vena cava. When the superior vena cava is when the vena cava is obstructed, what will happen to the pressure behind that obstruction? That is going to elevate, right? And due to the increased pressure in the previous vessels, the JVP, the jugular vein, which is also draining into the vena cava, the pressure in the jugular vein is also going to get elevated, right?
Okay, just
Okay.
like tamponade, external. Okay.
Yes.
Thank you.
Okay.
Thank you.
So now in this photo, can you tell me what is the diagnosis here?
Pneumothorax.
Pneumothorax. You can clearly see there is a
Yeah,
pleural line. In this, the pleural line is visible. There is atelectasis on this side. And after that pleural line, there is no peripheral markings. See, in this area, there is peripheral markings, these whitish lines. But in this area, there are no peripheral lines, right? In this area, there is no
Yeah.
peripheral markings.
No
Because there is
bronchovascular
only
marking.
air here. There is no lung tissue here. Lung tissue is here. Okay? Which is now collapsed. Okay? Okay. Okay. Now comes to this. So what will happen to the hemothorax volume? Hemithorax volume. What will happen to that? The patient has pneumothorax. Okay. So which are the most likely occurred in the patient's right hemothorax and right lung compared to his pre-injury state? The right hemothorax, what will happen to the right hemothorax? Is it going to be larger in size or it is going to be smaller in size? Right hemothorax, the one which have the pneumothorax in it. Will the chest wall
Going
is
to the
going
left.
to be spring outwards?
Thank you.
Outward.
Yes.
Outwards.
Yes, when there is air there, the chest wall is going to spring outwards. Okay, so that's why the right-sided chest wall would have a larger volume now.
increase.
Okay, so the hemothorax is going to be increased. What will happen to the lung compliance there? The lungs are collapsed here. So what will happen to the
Decrease.
compliance?
Decreased.
Yes, because now the lungs are less stretchy, right? Because now the lungs are collapsed. Because now you require a much higher force to expand the lungs, right? So lung compliance is decreased. They are less elastic now.
Can you explain this question?
Okay, so when you have when there is a hemothorax develop in the patient, due to the pneumothorax, the area which has pneumothorax, okay, in that area you are continuously filling the air there. The chest wall is going to spring outwards, okay, because of the continuous addition of the air in that area. Okay, and now there is no negative intrapleural pressure as well. Okay, the negative pressure is keeping the chest wall a little bit inside so that it can stick to the lungs. Okay, but now because of the pneumothorax, negative intrapleural pressure is no longer be present, and now the chest wall is going to be spring outwards and lungs are going to get collapsed, which result in an increasing chest wall size on the right side as compared to the previous pre-injury state. Okay.
Okay.
Okay, which of the following is most helpful in excluding a diagnosis of this patient? You people try to make a diagnosis here, and I will bring my charger.
This is a negative methacholine challenge test.
Yes.
It's negative metacolin challenge test. That's what we use for asthma.
So what is the diagnosis here?
C.
Diagnosis here. Diagnosis. The patient is suffering from what disease?
Asthma.
You actually told us about asthma.
Asthma.
Yes, it is asthma. And in asthma, to exclude asthma, methacholine challenge test. Okay. So diagnosis supported by spirometry and methacholine challenge test. Methacholine challenge test is a test in which we give methacholine. Methacholine is it is same like acetylcholine. And what does acetylcholine does? Acetylcholine is a product of parasympathetic nervous system, and parasympathetic nervous system causes bronchoconstriction.
Bronchoconstriction.
And in this, we are seeing whether the bronchoconstriction will be higher or not, whether the bronchi are hyperreactive or not. Okay, by giving methacholine. Okay, methacholine by giving methacholine, which is the same like acetylcholine. If the constriction, the bronchoconstriction, is very large, that means the bronchus are hypersensitive. Okay, that means that the patient has asthma, because in asthma the bronchus become hypersensitive to different allergens. Okay, so the test will be not the negative allergy, not normal, not the normal thing. This is going to be negative methylcholine challenge test. All of the other findings can be present in an asthma patient. An asthma patient can have normal IgE levels. They can have an asthma patient can have a negative allergy skin test, but then asthma patient cannot have negative methylcholine challenge test. Okay. So, this transudative causes of transudative pleural effusion.
Heart failure.
Cirrhosis.
Heart failure, cirrhosis,
Cirrhosis.
necrotic syndrome.
Okay. It cannot be B, right? Lung cancer causes exudative, right?
Yeah.
Malignant of
Yes.
obstruction of pleural lymph,
Exudate.
chylothoracic, exudative or exudative.
Exudative.
A obstruction of thoracic lymph duct. That is exudative or transudative.
Exudative.
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 Because hydrostatic pressure will increase in this case.
Lymphatic obstruction is
That is
exudative.
thoracic lymphatic flow. Thoracic lymphatic flow. We have
Lymphatic
done a
is
question.
exudate.
Yeah. Yes, it is exudative because we have done one question on that.
Exudate, yeah.
Remember that? Okay, now we are left
Yeah.
with two options, A and E. Rapid decrease in intrapleural pressure or fluid movement across the diaphragm.
E.
Fluid movement.
That's fluid mover across the diaphragm.
Okay,
Yeah.
let's see the question here. He has a history of cirrhosis due to chronic hepatitis C, 52, and inexperienced worsening dyspnea. Normal jugular venous pressure, right-sided dullness to percussion, and decreased breath sounds, normal heart sound, moderate size ascites, large right-sided with no parenchymal chain lesions. With no parenchymal lesions. Okay? So intrapleural pressure, in rapid decrease in intrapleural pressure also leads to transudative pleural effusion. Okay, and option A also leads to rapid pleural effusion. Option number E would be seen in what condition? Rapid decrease in intrapleural pressure.
Decrease with the oncotic pressure in the vessel.
Thorax.
In what lung pathology
No.
you are going to decrease a rapid decrease in intrapleural pressure?
Lung collapse.
Oh,
Yes,
okay.
Lung
in
fibrosis.
atelectasis, you are going to see a rapid decrease. In lung collapse, you are going to see rapid decrease in intrapleural pressure. Okay, but in our question, he has clearly mentioned on chest X-ray, there is a large-sided pleural effusion with no parenchymal lesion. Okay, that is going to eliminate option number E. So the only option we are left with is fluid movement across the diaphragm. Okay, so this question is of hepatic hydrothorax. Okay, it is not mentioned in the pulmonology that in cirrhosis patient usually also develops transudative pleural effusion on the right side, which we call hepatic hydrothorax. Okay, and the patient has ascites, which we also see that the patient has moderate ascites. Okay, due to the ascites, the pressure in the abdomen increases, and that increased pressure in the abdomen pushes the fluid into the chest cavity through the small holes in the diaphragm. Okay, leading to hepatic hydrothorax. Okay.
Is this similar to what we see in pancreatitis also, effusion, or it's different logic there with pancreatitis?
I think
It's
so.
different.
It's different
It's
because in
different.
this, yeah, it is different. So, the cause here is increased transabdominal pressure, which is and the increased transabdominal pressure is due to the ascites, and then the increased transabdominal pressure pushes the fluid through small holes into the diaphragm into the uh, chest area.
Okay, got it.
Which are the
Thank you.
following duties the patient most likely diagnosis is? Okay, 42-year, daytime sleepiness, falls asleep during the meetings while watching. He has even fallen asleep during driving, does not feel refreshed when waking, occasional morning headaches, visual when falling asleep, abnormal dreams. He has not had abnormal dreams, drinks 2 to 3 beers. BMI is 32. There is pulmonary hypertension as well. What is the diagnosis?
Obstructive sleep.
Obstructive sleep apnea. Okay.
High BMI.
High BMI. The
Morning
patient
time.
has daytime sleepiness. All the symptoms here, obstructive sleep apnea. Daytime sleepiness, obesity. Okay. And the somnolence symptoms, daytime somnolence symptoms. Okay. Okay, let's. Okay. And it also explains the hypertension. Morning headaches, snoring, heart failure. Okay. Okay. You have to tell me the diagnosis here. "25-year-old non-productive comes subjective fevers, right-sided pleural chest pain, increasing dyspnea. He was empirically treated for pneumonia with levofloxacin at urgent care center 2 weeks ago, but had no improvement. Exchange student from the Philippines, right-sided breath sound, large right-sided pleural effusion. The cause of this pleural effusion in this patient.
Maybe parapneumonic pleural effusion.
The cause is
Pneumonia.
The cause we give the patient pneumonia treatment. The patient does not
Not
improve with pneumonia.
Tuberculosis.
Tuberculosis.
It is tuberculosis. That's why
Migration
whenever
from
you see a patient of
Philippines.
TB, whenever
Yes.
he will tell you a patient of TB, mostly that patient's background will be from Southeast Asia. Okay? He will say the patient is from Pakistan, or it is from India, or it is from Philippines, or it's from Vietnam. Okay? The background will be Southeast Asia. Okay? He will give you some type of hint. Okay? And he has mentioned that treated for pneumonia but had no improvement. And on chest X-ray, large-sided chest CT, right upper lobe infiltrate, and a calcified hilar adenopathy. That means it is a reactivation TB. And TB cause exudative or transudative?
Exudative.
Exudative.
Okay. Okay. Now you have to tell me which one is consistent with exudative pleural effusion. Which one is consistent with exudative pleural effusion? Remember the lights criteria?
Protein concentration.
Yes. Lactate the high.
No, let's say LDH is going to be higher. It is not pneumonia. That's why it is not neutrophilic leukocytosis. We are not going to see neutrophilic leukocytosis. We are going to see lymphocytic leukocytosis. Okay. Tags, it is not chylothorax. It is not a cancer. It is TB. Okay. So C is the right answer. Remember this lights criteria. Pleural fluid LDH greater, pleural protein is going to be greater, pleural LDH greater than 2/3 ratio. Okay, 28-year-old healthy man, shortness of breath on ski vacation. Colorado, really mentioned the height. On arrival 4 days ago, experienced mild headache, nausea that resolved spontaneously. But since yesterday, worsening dyspnea and cough. Now feels short of breath even with minimal exertion. 86% hypoxemia. Pink mucous membrane, bilateral inspiratory crackles, and no murmurs or pedal edema. Chest X-ray reveals patchy alveolar infiltrates. Okay, what is the diagnosis?
I have to.
The diagnosis?
Pulmonary edema type.
Yes, pulmonary edema. What type? Cardiogenic or non-cardiogenic? Is it going to be cardiogenic or non-cardiogenic?
Non-cardiogenic.
I think cardiogenic.
Yes, it is going to be non-cardiogenic. Same like in the ARDS. Okay, it is going to be non-cardiogenic pulmonary edema.
Yeah, because patient has no heart murmurs or pedal edema in the flat neck veins. Yes.
Yes, it is a non-cardiogenic pulmonary edema, which occurs due to the high altitude. Okay, and what is the cause of non-cardiogenic pulmonary edema usually?
Hypoxemic vasoconstriction.
What happens in ARDS? What area is damaged in ARDS?
Alveolar capillary membrane is damaged actually.
Heavily, and the edema is of exudative type, right? The capillary permeability is increased. We are going to see protein-rich fluid, right?
Yes.
It's okay. So the diagnosis, so the right answer will be A. Embolic pulmonary. This is not pulmonary embolism. So option B cannot be the answer. Excessive decrease, no. A excessive decrease is not the cause of. If it is excessive decrease in PaCO2, we cannot explain the patchy alveolar infiltrates which we are seeing in the X-ray, right?
Yes.
It is not due to the heart failure. There is no pedal edema, no heart murmurs. Okay. Increased total red blood cell mass. There is polycythemia there, but that is not the cause here. That can be an effect, but that is not the cause here. So the disease is high altitude illness. Okay. In this, there is pulmonary edema due to the unbalanced hypoxic vasoconstriction. I don't think so. It is written in the first aid book. But the good thing is there is only one question on this.
So this can happen in previously healthy patients also. He didn't have any
Yes.
other problem. Oh,
Yes,
okay.
it is occurs due to the high
Mine was just the high altitude, yeah.
Okay, it occurs due to the high altitude. Okay, due to the high altitude, you are going to see an unbalanced hypoxic vasoconstriction leading to dyspnea, cough, and respiratory distress, and that's going to lead to increased pulmonary arterial pressure. Okay. Okay, let me see the photo here. This is the photo. Patchy perihilar infiltrates. Okay. So what is the diagnosis here?
Septic shock.
Extensive group A cellulitis. 35-year-old patient has high fever, shaking chills, develops rapidly worsening respiratory dyspnea, distress and hypoxemia, temperature evaluatory hypoxemia, okay, tachypnea, diffuse crackles, worsening bilateral alveolar infiltrates.
Again, pulmonary edema.
Yes.
Is it cardiogenic or non-cardiogenic?
Non-cardiogenic.
Because the on an echo you are seeing normal ejection fraction and normal valve function. Okay, the most likely the patient is suffering from ARDS. Okay, acute onset hypoxemia. Okay, and there is a diffuse bilateral alveolar opacity is here. Okay, and so at what area does this occur? Which should be the right answer? Is it mast cell degranulation? Is it anaphylaxis?
No.
No.
Okay. Okay. Is it pulmonary fibrosis?
No.
No.
Okay. Okay. Local lipocyte endotoxin lipocyte molecules. Yes. Okay. Now we are
B is
left.
the answer.
Okay. Directed by the local okay. Endotoxin is not produced by the group
Yeah,
A
A is
streptococcus.
not the answer.
Okay. So it is not because endotoxin is not produced by that. Okay. can cause. Okay, we are left with B and D. Option number B. A macrophage is it TB or sarcoidosis? It is not TB or sarcoidosis, right? So B is also not the answer. The only answer is neutrophil activation by stimulation of pattern recognition pattern. Sepsis leading to the ARDS. Respiratory abnormal bilateral lung opacity, hypoxemia, not due to heart failure. In causes, there is sepsis, most common, aspiration pneumonia, trauma, hepatitis. Okay. Neutrophil recruitment. And there is a toxin mediator. Okay. Okay. In this signals from the two polysaccharides. Okay. TAMPs and DAMPs, endothelial permeability, is ARDS. Will help confirm the suspected diagnosis in this patient. Diagnosis here. Sudden onset dyspnea, 55 years old male,
embolism.
international bank, returned from a business trip in Australia. Okay, so long distance travel in which he most probably he doesn't move his legs, due to which there is stasis of blood leading to venous thrombosis and eventually thromboembolism. Moderately or with
Thromboembolism.
tachypnea, shows sinus tachy, ventilation perfusion scan. So in pulmonary embolism, ventilation is affected or perfusion is affected?
Perfusion.
Perfusion.
So a perfusion defect without an associated ventilation defect. Okay?
Yes.
This pulmonary embolism. Okay, we are here already. Diagnosis. Very easy question.
OSA.
Obstructive sleep apnea.
Obstructive sleep apnea. 54, daytime sleepiness, lack of energy, progressive, completely drained by the end of the day, has works in a warehouse, BMI is 34, narrow oropharynx, large neck circumference, obstructive sleep apnea. And in obstructive sleep apnea, the complication is
Pulmonary hypertension.
pulmonary,
Pulmonary hypertension.
systemic, and pulmonary hypertension. Nocturnal hypoxia leads to systemic and pulmonary hypertension and arrhythmias as well. Okay, and sudden death. So the answer is going to be pulmonary hypertension.
E.
E. Okay. Administration which is most useful during the okay. So the diagnosis here. Occasional dyspnea that wakes him at night, 43 years age. Occasional dyspnea. Okay, so that's mean it does not happen every day. A severe upper respiratory tract infections is since then he has also has an episodic cough. His older brother has atopic dermatitis, bilateral normal breath sound with no wheezing and crackles. There is no extremity pattern. Pulmonary function testing is normal. What is the diagnosis?
Asthma.
Asthma.
Asthma. So if it is asthma, why the pulmonary function tests are normal?
So it's occasional. At that time, he would not.
Yeah,
Yeah.
because
And
it
if
is
you
occasional. When the person has the episode, when the person is currently suffering from the episode, then we will see an imbalance in the PFTs. Okay, but during the time period when the person does not has the episode, the pulmonary function tests will be normal. Okay, okay. When the PFTs are normal, what test do we do to exclude the asthma? Name the test.
PLCO.
What is the name of the test we do to exclude asthma if the
With
PFTs are normal?
methylcholine challenge test.
methylcholine challenge
Yes,
test.
Methylcholine.
methylcholine challenge test. Diagnosis supported by spirometry, obstructive pattern with bronchodilatation, but may be normal when not in exacerbation. So plus minus methylcholine challenge test. So what would be the answer here? Answer.
E.
E.
Methylcholine E.
E. Metacolin.
Okay. Okay, so this is the last question. A 60-year-old man, 3 weeks of history of fatigue, shortness of breath, and fever. Where? Fever. Temperature 105. Dullness to percussion at the right lung base. Moderate size, loculated pleural effusion. With multiple septations. Chest tube placement only a small amount of thick pus. What is happening here?
Empyema.
Empyema. What is empyema?
Pus.
Empyema is the pleural
Dilation.
Pause.
effusion caused by pneumonia. Okay? Empyema is a pleural effusion caused by pneumonia. The patient's fever is high. That means the effusion is most likely due to empyema. But now that empyema becomes a complex pleural effusion. That's why the fusion becomes thick. There is loculations. There are multiple separate fluid pockets there. There is fibrosis occur within the pleural effusion. Okay, so that's why when we try to drain out the pleural effusion, they we will able to get very less fluid. To destroy the fibrosis, which one of these following will be useful?
A.
A. Fibrin tissue plasminogen activator, because it destroys the fibrin. It is a fibrinolytic agent. Okay, so it can improve the drainage. Okay, it will destroy the fibrin, and in this way, it will break down the organized fibrin and will help in decreasing the fluid viscosity there. Okay. 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 So we are done for today. Okay.
Can you please share the today's ID since there were so many questions not from the pulmonology, so we can revise it later
No,
tonight.
all of these questions are from the pulmonology U1. I haven't selected anyone. If you select only pulmonology, pathology, and pathophysiology, you will see exactly these questions. None of these questions is from any other topic. But UWorld has given this question within the pulmonology, patho and pathophysiology.
Okay.
Okay. Okay. So this is all for today. So we will continue again tomorrow. Okay. 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 Bye bye. Okay,
Thank
please
you
leave
so
the
much.
okay. So please leave the leave the meeting, because when you leave the meeting, then we can download the recording. Okay, when everyone leaves the meeting, then we can download download the whole of this class and can upload. Okay, and the ones who had still does not give the payment, please send the payment to Dr. Ahmed or Dr. Hamza. Okay, bye bye. Okay. Bye.
Bye.